My name is Nicole Lamana. I work at Columbia University Medical Center in New York. I'm a CLL specialist. So mostly 99% of my practice is CLL patients, and I run clinical trials in CLL. Essentially, when I was training in internal medicine, I was fortunate enough to rotate at a major cancer center. At the time, I was rotating at Memorial Sloan Kettering and always put on the leukemia service. And so I had many mentors on the leukemia service who fostered my interest in treating the whole patient. And at the time, I didn't know I would really subspecialize or even go into cancer. I was really interested in the whole patient. But after several years of rotating on the service, treating leukemia patients was very much like treating all aspects. It wasn't just leukemia, it was every subspecialty of internal medicine. And so that really rang and resonated with me. And so I went on, applied for a fellowship, did my training, sub-training, and stayed on at Memorial Sloan Kettering as an attending and faculty, and started working with people who did CLL specifically. And so that was I sort of fell into it and continued to enjoy it and had a lot of passion and love for it and stayed ever since. The things that make me feel good about managing CLL patients are at the end of the day, walking out and saying, I'm glad I still do what I do, was really because patients are very grateful that we're looking for new therapies. Obviously, ultimately, we're looking for curative therapies, but they're very grateful that we're spending so much time in managing their symptoms, treating them because CLL patients are chronic in nature, so you see them all the time. They become extended family members. I mean, they really are with you for years, and so you get to know them and their family members very well, and they stay with you. So the patients are very, very grateful for what you're doing because you're continuing to constantly evolve the care, whether it be with traditional therapies, new therapies, clinical trials. And so at the end of the day, it's really the patient satisfaction when they're saying, thank you for being here and thank you for all you do. I walk away going, okay, all that hard work paid off. Because there obviously are a lot of frustrations in research, and we have lots of obstacles, but that's what keeps me going. So the cornerstones of CLL management, the field is changing quite rapidly, and there's many good things about that, and obviously there are many more questions that we need to be answered. So we're grappling with several new novel therapies, and we're trying to figure out how do we use them, both in relapsed refractory patients as well as in upfront and untreated patients, in high-risk patients and in older patients. And so we have lots more questions. We're thankful to have many new agents to utilize, but certainly there are many more questions. How do we sequence these drugs? What about the long-term toxicities of these agents? What about long-term pharmacoeconomics, compliance? So there's lots of unanswered questions in this new era of CLL with oral therapies, chronic therapies, and so we have lots of questions to figure out. And so certainly there has been a shift in paradigm of a little bit of moving away from more traditional therapies. But I don't think we're quite there yet, and we certainly need to figure this out over time with more clinical trials and figure out how to strategize what may be best for all patients, but certainly for different patient populations within CLL. From my understanding of, obviously, CLL is a very complicated disease. So from what we do know about the molecular and the biology and the pathophysiology of CLL, these new therapies certainly may alter the treatment for certain subgroups. But I think, for instance, the patients with the 17p deletion, there's no doubt that the novel agents have transformed the treatment of that particular patient population. But for other groups, I think as we're learning that it may not be so simple. And so we're trying to see whether or not certain mutations are going to come about by utilizing certain agents, or on the contrary, will other mutations be suppressed? So we have a lot to learn with in the era of the new therapies, actually how we're going to how we're going to use them in context of this very heterogeneous disease. This is not one disease. And so I think we haven't yet figured that out. Hopefully in the context of many of the clinical trials that are running, we're also going to be gaining that knowledge with the data by looking at minimal residual disease, by looking at genomics, by looking at all these, and maybe we can partition that out and figure out best ways of whether these drugs need to be used alone or in combination, whether it be with traditional therapies or with other novel agents, to see if it does change the pathophysiology of the disease. So I think it's rather immature and young, but obviously it's exciting because it certainly gives us the promise that we can do things and may be able to manipulate things for the better. since being a CLL specialist, I think it's really important that patients consider clinical trials. These are rarer disease in general. The complications of these diseases can be unusual. And also, if we're going to try to figure out how these newer agents play into the care of patients with CLL, the only way to do this is really by participating in clinical trials. What I'm concerned about is that what's going to happen is with the approval of all these new agents, that patients are going to be exposed to these new agents, and and obviously with good intention, but the point is we may not learn about what they're going through, what the potential long-term toxicities of these agents are, or about their disease, what may happen when they relapse from whatever agent they may be on. Do they have new mutations that we need to identify? So if they're not part of clinical trials where we can capture this information, we're limiting ourselves by what we can do. And then many agents will get approved and we won't know how to use them, or how to use them to the best of their ability. So it's really, really important to have patients participate in clinical trials. While we're all excited about what's going on in CLL, what makes me nervous is that we're sort of jumping in feet first, and we really have to thoughtfully do this carefully as a community, so that we can certainly advance the field, but also that we don't lose those patients as the drugs get approved, because then it'll be done in the community. I mean, I know it's different depending upon the country you may be from, but certainly in the US, we're very nervous that we're gonna lose that ability to capture patients on clinical trials. And so I think it's important that we're very excited about what's going on, but at the same time, we need to temper our enthusiasm because we have so many unanswered questions.